come with the case. If somebody has come with the case, we can have a discussion from your case, or I have brought a case so that that can be discussed. What would you like to have? Anybody who has brought a case? Okay, if there are none, then I will go with my case, and I would like one of you to volunteer so that. Can you see the slide? Hello?
Yes, sir, we can.
Sir. Okay. So I will make it. Okay. Okay. Any volunteers to start the case discussion? Anybody? Anybody can volunteer. Those who want to perform very well in the examination, I think they should come forward, discuss the case, and gain experience, so that the examination will be just a walkthrough. Navjot, would you like to start? Is Navjot over there? Anybody else who would like to start? There should be somebody to lead the discussion. I can help you, no problems. Nitin, are you around there? Nitin? Who else is there who would like to discuss the case? Anybody? You come forward. Hello.
Good evening, sir.
Good evening. What is your name?
Sir, I'm Ramesh from Mumbai, sir.
Okay, fine, great. You are from Mumbai, Lilavati?
Yes, sir.
Okay, right, great. Okay, you start the case, and as you proceed, you can discuss it. Let us start.
Okay, sir. It's a 48-year female patient.
Okay.
Came with complaining of palpitations since last 12 years, exertional breathlessness since last 6 years, and edema of the leg since last 6 months. History of present illness. Patient symptoms were noticed first 12 years ago when she ran to get into a running bus and felt fast regular palpitation. Quickly settled. Subsequently, she is feeling regular fast palpitation at night on lying down off and on. She had no significant restriction of activities at that time. As she was leading a normal life, she did not consult a doctor. She started developing an exertional breathlessness for the past 6 years, NIH class 2. She consulted a doctor who told her that she has a heart lesion, most likely a wall narrowing, and need an investigation to decide the diagnosis and management, and referred her to the cardiologist, which she did not pursue. No medication were prescribed. She developed irregular palpitations 6 months ago. With the development of irregular palpitations, she becomes more symptomatic, NIH class 3. Associated with these symptoms, she had edema of both the legs, no history of PND, no history of exertional syncope, no history of exertional or rest angina, no history of spitting of blood. She consulted a doctor 6 months ago and was put on medication. The doctor told her that she had a heart disease and required scanning to reach a proper diagnosis. She was prescribed 3 drugs. One made her pass urine, another to be taken 5 days a week, and third one, which she was told is a blood thinning pill. Past history, she had a history of joint pain affecting multiple major joints at 10 years of age, which settled within a week. She took Ayurvedic treatment. No cardiac symptoms at that time. Married, had 3 children. Pregnancy were uneventful. She was not told about any heart disease during the delivery. Last childbirth 20 years ago. Family history, no history of heart disease in the family, no history of diabetes, hypertension, or a sudden death in the family. Personal history: attained menopause 1 year ago. No habits.
So now you discuss the story and what all conclusions can you draw?
Sir,
First question is this a heart disease?
uh,
Is she having a heart disease or is it something else, some other system?
she is having heart disease, sir.
Why? Why are you saying that?
First one, it's because she has had a palpitation.
Yes.
And
Yes.
second
Your
thing,
symptoms referable to cardiovascular system disease like
yes,
palpitation,
yes, sir.
breathlessness, edema of the legs, all indicate a cardiovascular system disease. What?
Yes, sir. Second, she has attended the doctor and he told that she had some heart disease and she has
Yes.
put on the medication.
Yeah.
For
Two
that.
doctors have told her that she has got a heart problem and she was put on medications which from the description seems to be drugs used in
Yes, sir.
treatment of heart disease. Okay, very good. So she has got heart disease.
అటువైపు లైట్
So,
Yes, sir.
what do you think? Is this a left-sided
అదేస్తే
disease or
మరి
a
లైట్
right-sided
ఉంటుందని ఆ చిన్న
right-sided disease? Is it a left-sided disease or a right-sided disease?
It looks like more of right-sided disease, sir.
Why did you
Sorry,
say that?
left-sided disease. Sorry, left-sided disease, sir.
Why did you say it's left-sided?
No, sir, it's left-sided. Sorry.
Why did you say that it's a left-sided disease?
Because of the exertional breathlessness.
Oh.
And exertional breathlessness is more common in the left-sided disease.
Yeah. No, but the exertional breathlessness is an important symptom of left-sided disease. But the right-sided disease, there is some noise coming. Somebody who can mute themselves so that it does not disturb our teaching program. Okay, so exertional breathlessness is mostly a left-sided symptom. Can exertional breathlessness occur in right-sided disease?
Yes, sir. It can happen in the right-sided disease also. Secondary to
best example is that in patients with primary pulmonary arterial hypertension, their very important symptom is exertional breathlessness. What are the mechanisms of exertional breathlessness of the left-sided disease, right-sided disease? Why do they develop exertional breathlessness in a left-sided disease?
In left-sided disease, because of the in stenotic and regurgitant lesion, there are different mechanisms, sir.
Okay.
In stenotic lesions, with the exertion, they doesn't cope up with the relaxation time is decreased, so they increase the back pressure and pulmonary congestion occurs.
Now you don't have to describe all this. You can say that exertional breathlessness is secondary to pulmonary venous pressure.
Yes, sir.
Pulmonary venous pressure elevation. There are different mechanisms for pulmonary venous pressure elevation. In mitral stenosis, it is because of the obstruction to the flow across the mitral valve and subsequently left atrial pressure goes up, which reflects onto the pulmonary veins and give rise to pulmonary venous pressure elevation. In a patient with any condition which can give rise to left ventricular hypertrophy, as can happen in patients with systemic hypertension or in patients with aortic stenosis, left ventricular hypertrophy can result in reduced compliance of the left ventricle, and with exercise, the left ventricular diastolic pressure can go up, the pressure can go up, and pulmonary venous pressure can subsequently get elevated. So ultimately, it is the pulmonary venous pressure elevation which causes the breathlessness in a patient with left-sided disease. Okay, so there are different reasons how this pulmonary venous pressure can really go up. In patients with left heart failure, left ventricular failure, the diastolic pressure can go up, the left atrial pressure can go up, and these patients can have pulmonary venous pressure elevation. And what level of pulmonary venous pressure elevation patients start developing exertional breathlessness? Ramesh?
Above 18 mm.
Above 18 definitely. Above 15 also they can start developing, but above 18 they definitely develop. And at what level of pulmonary venous pressure they develop pulmonary edema?
About 23.
Above?
23?
No, 25. Above 25. When it goes above 25, they can develop pulmonary edema. But in patients with mitral stenosis, sometimes even at 25 they do not develop pulmonary edema. Many times they may be able to tolerate pulmonary venous pressure even up to 30. What is the reason?
Because of the chronic increase in the pressure.
Okay.
Because of the chronic increase in the LA pressure, the pulmonary veins get acclimatized.
That's right. But they develop pulmonary edema may not develop at 25, which is the usual level at which patients develop pulmonary edema. But very often it may be much higher, maybe 28 or 30. Can you give the explanation? Anybody else who is? Can somebody give an explanation for that?
Sir, it is because of the chronic nature that they may develop pulmonary arterial hypertension. So
Very
the
good.
blood flow to the lungs, it decreases.
That's
So
right.
usually
That's
when
right. No, but that will decrease the pulmonary venous pressure. But
yes,
even when the pulmonary venous pressure is 25, they may not develop pulmonary edema. They may develop only sometimes at a higher level. What may be the reason?
so because the lymphatic drainage also increases with the chronic.
Very good. There are many multiple mechanisms. One is the improvement and efficiency of the lymphatic drainage. Very good. Two. Anybody? What is the next mechanism? The pulmonary arterioles can develop media thickening and some degree of fibrosis. That also will provide a protection for the development of pulmonary edema. So many times in patients with mitral stenosis, the pulmonary edema, especially chronic pulmonary venous congestion patients, it may take even slightly higher pressure for the development of pulmonary edema. Otherwise, it usually occurs at 25 millimeters of mercury. Is there any situation where pulmonary edema can occur at a lower pressure, lower pulmonary venous pressure?
Acute MR, sir. Or
Acute MR also it will occur only when it is at 25. Any situation where pulmonary, say what is pulmonary edema? What is the mechanism of edema formation? Maybe in the periphery, maybe in the lungs. What is the mechanism in the periphery?
the interstitial fluid is shifted to the alveolar.
First thing, what is happening in the periphery when there is an edema? Edema is because of the
increased fluid, which is not being compensated for. Sir.
Increased hydrostatic pressure, sir.
Increase the hydrostatic pressure. Two forces are there, osmotic pressure and hydrostatic pressure. And when the hydrostatic pressure is more, that can give rise to
Edema.
fluid transudation and development of edema. On the other hand, what can happen to osmotic pressure?
Yes, sir. If hypoalbuminemia is there.
Very good. If there is a osmotic pressure comes down, as in conditions like hypoalbuminemia, even with a lower hydrostatic pressure, the patient can develop edema. The same thing can happen in the lungs also. So in patients with hypoalbuminemia, they can develop pulmonary edema even when the pulmonary venous pressure is less than 25 or sometimes even 20. That is because the osmotic pressure comes down and the minimal increase in hydrostatic pressure may be enough to give rise to transudation of fluid and development of pulmonary edema. Okay, so that is the mechanism or development of breathlessness in the patient with left-sided disease. So you said there can be exertional breathlessness in right-sided disease also. What is the mechanism? Ramesh, what is the mechanism of development of exertional breathlessness in right-sided disease? Anybody, any volunteers who would like to try?
Decreased cardiac output to the respiratory muscles.
Yeah, very good. One is where there's when the right side is in trouble, the cardiac output comes down because LV can pump only what the RV pumps, and that will result in reduced blood flow to different parts of the body, including the respiratory muscles, and so they become tired because of the lack of nutrition. Very good. Another point.
Other mechanism thought is that if there is an increase in the right heart pressures, the pressure in the coronary sinus also increases. So the coronary perfusion pressure can decrease.
Very good.
And that can lead to further decrease in cardiac output and also the back pressure.
More than that, when there is the coronary sinus is the venous drainage of the heart. So when the the venous pressure goes up, what happens to the myocardium?
So the
There will be
because coronary perfusion pressure will decrease.
That may not be affected very much because what is the thing besides coronary perfusion pressure?
Myocardial edema.
Yeah, myocardial edema. Very good. That's what happens. My coronary perfusion pressure is mostly decided by the diastolic pressure minus aortic diastolic pressure minus the LV diastolic pressure.
Okay.
But when the patient's coronary sinus gets congested, they can give rise to myocardial edema. And when the patient develops myocardial edema, that will result in reduced compliance and elevation of the pulmonary left ventricular diastolic pressure. Very good. Third point. There are multiple mechanisms for the development of exertional breathlessness. That is because no single mechanism is not enough to explain the whole process.
Again, the rise in the right-sided pressures will increase the pressure in the SVC. So the venous drainage as well as the lymphatic drainage of the lungs is also affected.
Okay, very good. The lymphatic drainage and that can also result in the development of pericardial pleural effusion. You can develop pericardial effusion. All these things can result in breathlessness. Very good. Yes. Fifth point. Two, at least two more important points you should mention. Any one of you?
Decrease blood flow from the pulmonary circulation into the lungs to get oxygenated.
Oh.
Some of blood going to the lungs is fixed.
Oh. So that we have already explained that RV pressure can, RV output can come down. Consequently, LV output can also fall. That will result in decreased perfusion of the respiratory muscles and then develop fatigue and the patient experiences breathlessness. That we have already explained. Any other mechanism?
Reverse Burnham effect, sir.
Very good. Reverse Burnham effect. Yes. What is it?
Sir, once there is a rise in there is a paradoxical shift of the IVS to the left side.
Very good.
It leads to subsequent increasing of LV-EDP, sir.
Yeah, because there is a reverse Burnham effect by means of which the intraventricular septum bulges to the left side of the heart, interfering with the cavity size of the left ventricle, resulting in elevated pulmonary, elevated LV filling pressures, resulting in pulmonary congestion. Very good. What else?
Coronary artery compression, it leads to because of dilated pulmonary artery.
Yeah, sometimes when the patient is having significant pulmonary arterial hypertension, sometimes coronary artery can get compressed, and that may result in ischemia and result in breathlessness. Another mechanism is the heart is a syncytia. So when the right ventricle is affected, right ventricular hypertrophy and right ventricular functional impairment, that can also have an impact on the left ventricle, resulting in some degree of LV dysfunction. And it is also described that when the pulmonary artery hypertrophy, pulmonary artery hypertension, it may press upon the left bronchus. The left pulmonary artery can press upon the left bronchus, and that can result in symptom of breathlessness. And finally, there are certain receptors in the lung known as J receptors, and the stimulation of the J receptors also give the feeling of breathlessness. So there are many mechanisms by means of which the breathlessness in a patient with right heart disease can be explained. So obviously it means that it may not be a single mechanism, but multiple mechanisms. So exertional breathlessness, even though it is mostly a left-sided symptom, sometimes can we get that somebody whose noise is coming? Can you mute yourself? So that does not disturb others. Can you mute yourself so that you don't disturb others? Okay, so there are different mechanisms. So we have to keep in mind that exertional breathlessness can still be an important symptom of left-sided disease, but since there is no history of paroxysmal nocturnal dyspnea, you can't be 100% certain that it is a left-sided disease. We'll keep it in mind. Okay, yes, what else? Or what is the next thing that you can think about? So we are not sure, but that there is a right-sided involvement because she has developed edema of the different parts, and so we would like to think that either it is a biventricular involvement or mainly a right-sided disease. Okay. What is the mechanism? What is the hemodynamic mechanism of her disease? Ramesh, what do you think is the hemodynamic mechanism of her disease?
Her palpitation mostly is because of the uh, uh, arrhythmia, sir. And
Not the arrhythmia. She ran for a bus and then she developed a palpitation. At night, she is feeling some palpitation. We can't be certain that it is arrhythmia. It could be a palpitation, maybe a symptom of the disease process. And in what type of hemodynamic disturbance you get palpitation as an important symptom?
Volume overload.
regurgitation, sir.
In volume overload. You first say volume overload. What are the conditions which can give rise to volume overload?
Regurgitant
Regurgitation.
mitral regurgitation, aortic regurgitation.
Yeah, mitral regurgitation, aortic regurgitation, tricuspid regurgitation, pulmonary regurgitation. All right. What else?
Shunts.
Shunt lesions. Very good. Shunt lesions. Atrial septal defect, ventricular septal defect, patent rectus arteriosus, ruptured sinus vessel. There are a number of conditions where there can be a shunt, and that also can give rise to palpitation as because of the volume overload. So palpitation is a volume overload symptom of a volume overload condition. She had palpitation for 12 years before she started becoming really symptomatic. Okay. So what is the thing which really brought about her symptom, which forced her to go to a doctor?
Edema, like, sir.
More than that, she developed some irregular palpitations.
Yes, sir.
And subsequently she became more symptomatic. So what is the thing which has happened?
She must have developed atrial.
Arrhythmia, sir, atrial fibrillation.
She has developed atrial fibrillation. Most likely she has developed an atrial fibrillation which tilted the balance. So why does atrial fibrillation give rise to breathlessness? Or why does the atrial fibrillation give rise to aggravation of symptoms?
One is because it decreases the atrial kick, sir.
Not decrease, it removes the atrial kick. There is no more atrial kick.
That's why there is back pressure and pulmonary venous pressure increases.
Now you have to describe it. What happens? Not enough. When the atrial kick is removed, what is the hemodynamic change?
Left atrial pressure will increase.
Yeah, mean left atrial pressure will increase. Why the mean left atrial pressure will increase? Why does the mean left atrial pressure increases? Anyone of you?
Almost 30 to almost 20 to 40% of the filling of the LV is occurred with the left atrial kick, sir. So
wrong. No. Can you tell me what is the pattern of filling of the ventricle during diastole? What are the phases of ventricular filling?
it's early rapid filling.
Early rapid filling.
And then
There's nothing like early rapid filling. Okay, early rapid filling. All right. Yes. Second.
And then with the atrial kick.
No. Next phase.
Passive
Diastasis.
Diastasis or slow filling. Okay, slow filling phase. And third is
Atrial systole.
atrial systole and related filling of the corresponding ventricle. Can you tell me in a young individual or a normal person, what is the pattern of filling? What percentage of filling of the ventricle takes place during early filling? What percentage takes place during diastasis? And finally, what percentage of filling takes place during atrial contraction? Anyone of you?
Maximum during early rapid
That's right.
filling.
But you have to tell me approximately what will be the percentage. And only it's complete. Because you should know all these things precisely and exactly.
80%, 5%, and 15%, sir, around.
In a slightly different order, you are right. Almost 75 to 80% during the rapid filling phase, and about 10%, or sometimes even slightly more, 10 or at most 15, mostly 10% during the diastasis, and another 10 to 15% during atrial contraction. So the contribution of atrial contraction and normal healthy ventricle, which can easily dilate and suck the blood from the left atrium, is very little. But there are situations where the LV cannot easily dilate, and cannot suck the blood from the left atrium. And in these conditions, there is a higher contribution of the atrial kick or ventricular filling. Can you tell me the situations where there is the need of higher atrial contribution to ventricular filling? Few conditions.
Mitral
Microstenosis.
No, mitral stenosis, atrial contraction can hardly increase the ventricular filling.
Diastolic dysfunction.
No, you should know.
secondary to the hypertension.
Yeah, where there is a impaired relaxation, conditions associated with left ventricular hypertrophy. In those situations, there is a impaired relaxation, or the relaxation of the ventricle is impaired, resulting in much less filling during the rapid filling phase. And because of that, what happens in the left atrium?
Left atrial pressure increases.
Left atrial pressure increases, left atrial volume increases. That will result in a increased force of contraction of the left atrium when it contracts, because according to Starling's law, when the stretch increases, there is an increase in the force of contraction. So the left atrial contraction increases, that will result in a much better filling of the ventricle, which is known as atrial kick. And that will be clinically, that can be detected by S4. It can be sometimes even palpable, or it can easily be heard, and sometimes it becomes palpable. That will tell you that there is a active contraction of the ventricular atrium, and that helps the filling of the ventricle during a late diastolic phase. And the conditions associated with active contribution of ventricular filling by the atrial contraction are whenever there is a left ventricular hypertrophy, like systemic hypertension, aortic stenosis, hypertrophic cardiomyopathy. All these are the conditions where there is a significant contribution of ventricular filling by the atrial contraction. And it is said that sometimes the atrial contribution to ventricular filling can be as high as 40 to 50%. So in these situations, when the patient develops atrial fibrillation, they develop quickly symptomatic of the right. So when there is a atrial contraction is taken away, the emptying of the atrium is interfered. That will result in stagnation of blood in the corresponding atrium, and the mean atrial pressure goes up. And that is why these patients develop. One mechanism is, that is one of the mechanisms of development of symptoms. They develop mean atrial pressure, especially left atrial pressure goes up. Second, when these patients, when they develop atrial fibrillation, and sometimes when they exercise, what happens? In patients with atrial fibrillation, when they exercise, what happens?
The rate goes up and the
rate goes up disproportionately. When the rate goes up disproportionately, what happens?
Diastolic
Diastolic comes down, diastolic filling becomes impaired, and that will result in less of cardiac output.
Aggravation of symptoms.
So atrial fibrillation is the commonest stable arrhythmia which tilt the balance in an otherwise stable patient. Can you tell me some conditions where there can be atrial fibrillation? 10, 15 conditions. Atrial fibrillation, it's a very simple question. Conditions where there can be, the common conditions you can easily answer. I would like
Age-related.
Hypertension, very good.
Age-related.
Age-related, why should you say? I agree with you that as age advances, the incidence of atrial fibrillation goes up. I agree with you. But
Yes,
unless there is some underlying problem,
Yes,
like
sir. Hypertension, cardiomyopathy, OSA.
LSIs. Any condition leading to increase in LSI, like mitral stenosis.
Okay, mitral valve disease. So you said systemic hypertension, mitral valve disease. Both
Hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathy.
Obesity, OSA.
Obesity, okay, especially Precordial syndrome, obesity, yes. Especially patients with sleep apnea, obstructive sleep apnea,
Obstructive
yes.
sleep apnea.
Restrictive cardiomyopathy.
Constrictive pericarditis, restrictive cardiomyopathy, very good. Constrictive pericarditis, dilated cardiomyopathy, yes, what else?
ASD.
ASD, very good, excellent, ASD.
Post-surgical.
Post-surgical, very good. Post-surgery patients, trauma to the atrium, they can develop atrial fibrillation. Very good. Excellent. Very good. What else?
The electrolyte abnormality.
What electrolyte abnormality?
Hyperthyroidism.
Hyperthyroidism. Hyperthyroidism, very good. Not electrolyte abnormality. That's not usual.
Pregnancy also.
No, pregnancy, they can have atrial and ventricular ectopic bits, not atrial fibrillation. That's very uncommon.
WPW.
WPW, of course, when they develop atrial fibrillation in a patient with WPW, I agree with you, and especially with multiple pathways. Patients of WPW with multiple pathways have got higher risk of developing atrial fibrillation. Okay, very good. Yes.
Pneumonia and sepsis. Pneumonia and sepsis.
Yes. Pneumonia, sepsis, toxemia can give rise to atrial fibrillation. Trauma can give rise to atrial fibrillation. And electric current, electric trauma, especially lightning, can give rise to atrial fibrillation.
Sarcoidosis.
Sarcoidosis usually gives rise to ventricular arrhythmias, mostly, because the problem is in the ventricle, and they usually give rise to ventricular arrhythmias.
Yes, sir, certain familial.
So due to alcohol binge.
Yes, alcohol binge, acute alcohol intake can give rise to transient atrial fibrillation. Very good. Yes.
Can be drug induced, sir.
Like?
Ivabradine.
I don't know whether there is a slightly higher incidence of atrial fibrillation patients who take
Around 10% patient can get AF.
But most of them have got a basic disease which itself can lead to atrial fibrillation. So, okay, you can say that ivabradine can induce atrial fibrillation. Very good. I'll accept that. Okay, yes. Any other? Did we say core pulmonale? Core pulmonale can give rise to, yes.
Ischemic heart disease.
Mention the most. Yeah, that's the most important thing. See, whenever you are asked a question on arrhythmia, always first say ischemic heart disease. There is no arrhythmia which cannot be caused by ischemic heart disease. So always tell that first answer as ischemic heart disease. So these are multiple reasons, about 15-20 reasons which can give rise to atrial fibrillation. So in this patient, what are the situations which you would like to consider? Ramesh?
ASD I would like to consider, sir.
ASD can be considered because patient is having palpitation, walling overload,
right
and has got mostly right heart symptoms. Can these patients with ASD present at this age?
Can be, sir.
Yeah. Why do patients with ASD develop heart failure at this age? What is the difference in the natural history of patients with VSD, PDA and ASD? What is the difference?
The VSD PDA patient develops early ISN mineralization, sir, whereas each patient develops late ISN mineralization.
They may develop late from ISN mineralization or may not develop ISN mineralization at all.
Yes,
Why they don't develop ISN mineralization? What is the mechanism?
Because of the increased pulmonary blood flow, sir.
Now, why do they have increased pulmonary blood flow?
Because of
what happens? What happens to a patient with VSD, PDA when as they grow? And what happens to a patient with ASD when they grow? What about the shunt? What happens to a shunt? What happens to pulmonary artery pressure?
VSD and PDA usually tend to decrease in size as the child grows, and the pulmonary shunt size usually tend to decrease with as the age advances, sir. If they are if they are small shunt, they can be closed by.
So small shunt is not the problem. In a patient with large VSD and large PDA, where there is a torrential shunt, what will be the natural history?
So in VSD and PDA, both pressure as well as volume is transmitted to the pulmonary circulation.
Very good.
So develop it early. In ASD, it takes a longer time because only the volume overload is there. That's why they take longer time to develop pulmonary hypertension.
Not fully correct. You have to explain it a little more. I agree with you that in VSD, the pulmonary circulation is in touch with systemic circulation in which phase of cardiac cycle?
Systole.
Systole. And in PDA?
Systole and diastole.
Both systole and
Both
diastole.
systole and diastole.
What about ASD?
Actually,
It is not in connection directly with the pulmonary circulation.
No. The systemic circulation is not connected to the pulmonary circulation because it is a free tricuspid shunt, and because of that, the systemic circulation is isolated from the pulmonary circulation. Okay, yes. Then why is in a patient with BSD and PDA, as the age advances, there is if it is a large PDA, large VSD, what happens to the pulmonary vascular resistance? What happens to pulmonary arterial pressure?
Usually increases, sir.
It increases, not usually, it increases.
Yes, sir, it
Pulmonary
increases.
vascular resistance increases, consequently pulmonary arterial pressure increases, and they gradually develop Eisenmenger syndrome. And for Eisenmenger syndrome, what should be the pulmonary resistance?
Pulmonary pressure should be systemic or suprasystemic.
Need not be systemic. Pulmonary, what should be the pulmonary vascular resistance when you label it as Eisenmenger syndrome?
more than 6.
More than 8 even.
More than 6 is not enough. It should be more than 10. More than 6 is a contraindication for a closure unless you can reverse it. 6 or 7. But when it exceeds 10, then you call it Eisenmenger syndrome. By above 7, actually there is you have to demonstrate that by an intervention you can bring down the pulmonary vascular resistance to below 5. Then only you can have an intervention. Otherwise, the patient may progressively develop something like a significantly elevated pulmonary resistance and pressure, and they may succumb to the disease quite early. So the more than 7 is actually a more than 6 to 7 is a contraindication for closure of the defect. But you can, if you can demonstrate that it is if there is an element of increase in the vascular load, and that can be reversed by interventions and can be brought down to below up to 5 or below 5, then those patients can be operated. So in patients with VSD and PDA, they develop progressive pulmonary vascular resistance and pulmonary arterial hypertension. What happens in ASD? What happens in ASD?
ASD usually the right ventricle, sir, as the one is that, as already explained, the systemic circulation is not in direct contact with the pulmonary circulation.
Very good.
So there's over the time, even if the pulmonary pressures increase, it is taken care of by the right ventricle till the time, and usually, and it may fail. Right ventricle can fail. The right ventricle can dilate. There can be cardiomegaly. There can be TR, which can occur.
No. You have to explain it. See, what is the thing which decides the shunt in VSD and PDA?
Sir, it will be the pulmonary vascular resistance which is going to decide that.
No. Pulmonary vascular resistance is right, but it is the pressure difference between the systemic side and the pulmonary side. If the systemic pressure is higher, then the shunt will be from left to right. And if as the pressure rises in the pulmonary arterial system, it may become less and less and less, and ultimately it may become right. So the elevation of the pulmonary vascular resistance and elevation of the pulmonary arterial pressure results in the decrease in the left to right shunt, and consequently at a certain stage, when the pulmonary arterial resistance exceeds the limit, it can even become right left. What is the thing which decides the shunt in ASD?
It will be the two atrial, right ventricular and diastolic pressure, and the right atrial pressure finally.
Not enough. Now, not enough. What is the thing which decides the shunt in a patient with ASD?
So are we compliance?
Very good. It is the compliance of the ventricle. So if the patient is having if there is a normally the compliance of the right ventricle is much more than the left ventricle, and as the age advances, the left ventricular compliance really comes down, because many of them may develop some LV fibrosis or may develop some degree of systemic hypertension and pulmonary left ventricular hypertrophy, and hence the pulmonary LV compliance comes down, and that will result in what?
LV pressures will increase. LA pressure will increase.
Yeah, no, LV pressure may not increase in a patient with ASD because it will be immediately decompressed. When the LV compliance comes down, what will happen to the ASD shunt? What will happen to the shunt?
Increases.
Increases. So that is a big difference that you should understand. That in patients with BSD and PDA, the shunt is depending upon the systemic resistance, systemic pressure in comparison to what is the pulmonary arterial pressure and pulmonary resistance. And as the pulmonary vascular resistance goes up, pulmonary arterial pressure goes up, the shunt becomes less and less, and finally becomes right to left when the patient has developed Eisenmenger syndrome. While in a patient with ASD, the thing which decides the shunt across the atrial septal defect is the relative difference in the compliance of the left ventricle and the right ventricle. The right ventricle. Hello? Or can you switch off the? Can you mute yourself so that other noises does not come to the teaching program? Please. So, in a patient with ASD, it is the compliance of the difference of the left ventricle and the right ventricle which decides the left to right shunt. As the age progresses, there is a decrease in the compliance of the left ventricle, and hence, in a patient with ASD, actually, as the age advances, shunt becomes more and more. Shunt becomes much more prominent, and more shunt occurs. And when the shunt becomes more and more, RA and RV dilate, and ultimately RV fails. So in a patient with ASD, and also the LV size becomes quite small also, and these patients can develop right heart failure at a late stage in life, maybe at the age of 40 or in the 5th decade or so. And these patients, because of the RA dilatation, can develop atrial fibrillation. So atrial fibrillation is a complication which can happen in a patient with ASD, but it cannot happen in a patient with VSD with PDA. VSD and PDA, very unusual. So the atrial fibrillation is one opening overload condition where the patients can develop more and more shunt, right ventricle and the right atrium can get enlarged, and they may present with heart failure in the 4th or the 5th decade. So there is one possibility. What else? Any other possibility in this patient?
Sir, I have one question, sir.
Yes. Yes.
Rheumatic heart disease.
Yes.
Yeah. Yes. What did you say?
Rheumatic heart disease, mitral stenosis earlier, followed by mitral regurgitation.
Yes, we have to discuss. It could be a rheumatic heart disease because she gives a history of joint symptoms at the age of 10, and the rheumatic heart disease patients can present. But then, why is she having not left no history of paroxysmal nocturne dyspnea even after she has developed atrial fibrillation? She does not have any history of paroxysmal nocturne dyspnea. How can you explain that?
Usually, when the right heart failure occurs, the left heart symptoms may decrease. But
okay, when the right heart failure occurs, left heart symptoms. But when the right heart failure can occur secondary to the elevation of the pulmonary venous pressure, then going in for pulmonary arterial hypertension. What are the mechanisms of development of pulmonary arterial hypertension in a patient with mitral stenosis? Navjot.
Sir, when the long-standing mitral stenosis, there will be chronic pulmonary venous hypertension. So it may to the back pressure to the arterioles, and the artery will finally the media will hypertrophy, and they can develop pulmonary arterial hypertension.
Very good. A passive elevation of the pulmonary arterial hypertension, pulmonary arterial pressure secondary to elevation of the pulmonary venous pressure. When the pulmonary venous pressure elevates, there is a passive elevation of the pulmonary arterial pressure. Very good point. Second point.
Due to vasoconstriction, sir.
Yes, reactive and protective and reactive vasoconstriction of the arterioles. Very good. Third point.
Fibros of
Yeah, very good.
Pulmonary arteriopathy.
Yeah, it can give rise to the medial hypertrophy, fibrosis resulting in obliterative arteriopathy. So there are three mechanisms. One is passive elevation of the pulmonary venous pressure resulting in elevation of the pulmonary venous pressure resulting in passive elevation of the pulmonary artery pressure. So reactive and protective vasoconstriction that can result in pulmonary arterial hypertension. And third, hypertrophy of the media with obliterative arteriopathy resulting in obliterative arterial hypertension. So all these things happen only as a sequel to development of pulmonary venous pressure. And when the patient has developed pulmonary venous pressure, I expect the patient to have some degree of pulmonary congestion resulting in a symptom of paroxysmal nocturnal dyspnea. So what can be the mechanism which can protect the patient with mitral stenosis from development of pulmonary development of paroxysmal nocturnal dyspnea?
Maybe a decompression at the level of atria, like a ASD, like a Lutemberger syndrome.
Okay, very good. Lutemberger syndrome can give rise to can protect the patient from development of paroxysmal nocturnal dyspnea in a patient with mitral stenosis. So then you are saying that this patient is having congenital heart disease and also rheumatic heart disease. I'm asking a question. If the patient is having rheumatic heart disease only and as having mitral stenosis with mitral regurgitation, which was proposed by one of the participants, what can be the situation where the paroxysmal nocturnal dyspnea may not happen? How can somebody be protected? How does the pulmonary hypertension protect against development of pulmonary development of paroxysmal nocturnal dyspnea? Ajot?
Organic tricuspid stenosis.
Very good. Excellent. When there is an organic tricuspid stenosis, that will result in less of RV filling, less of RV output, and that can protect against the development of paroxysmal nocturnal dyspnea. If the patient is having multiple lesions and the lesion to manifest will be, what is the principle?
Proximal lesion manifest.
Proximal lesion, very good. Proximal lesion will manifest. So in a patient with mitral stenosis and tricuspid stenosis, the symptoms will be more referable to tricuspid stenosis because the patient is protected against the development of pulmonary congestion because the RV is not able to pump adequate blood because pulmonary congestion because of the mitral stenosis. So the tricuspid stenosis and mitral stenosis, the symptoms will be more of tricuspid stenosis. So if the patient is having significant tricuspid stenosis, then the patient may not have any symptoms or maybe minimal symptoms referable to the left-sided disease, and mostly it can be a right-side symptom. Okay. Do you think that this patient might have had some other disease which is purely a right-sided disease? Do you think that the patient can have carcinoid? Mesh, do you think that is a carcinoid case?
Less likely because she's not having other symptoms.
No constitutional symptoms.
No constitutional symptoms. So, so what is carcinoid? What is the problem in carcinoid?
Increased production of
production of
5-hydroxytyramine.
Okay.
Serotonin.
Okay, serotonin. It produces serotonin. Serotonin is released from
neuroendocrine tumor.
Oh, what is the name of the what is the name of the cell?
Enterochromaffin cells.
Argentophilin cells. Argentophilin cells. It is argentophilin cells, and mostly it is in the appendix. And normally serotonin is intoxicated where? How does the serotonin reach the liver or reach the heart to produce heart lesion?
Sir, unless the patient has metastasis, usually liver is involved. unless the liver is involved, it will not manifest in the heart because it is liver it is metabolized. The fiber.
Very good. Serotonin is metabolized in the liver and it does not reach the heart. Reach the heart. But in patients with a malignant argentinophenoma, they can have secondaries in the liver, and these secondaries can secrete serotonin, and that can give rise to heart lesion. What is the usual heart lesion? Navjot?
So usually tricuspid wall and the pulmonary, the right-sided walls are involved, the tricuspid wall and the pulmonary wall, and usually they produce TR.
Both. There is fibrosis resulting in both stenosis as well as regurgitation.
Right.
Actually, in the pulmonary valve, stenosis is more dominant than regurgitation.
Right.
But in the tricuspid valve, both can happen. Right. So can you get left-sided disease in carcinoid?
Yes, in case there is a communication, like there is a PFO or a ASD, so that the 5-hydroxy.
There is no communication. No communications.
Sir, if there is the lungs are also involved, there is the lung is the source of tumor.
Very good. If there's a deposition in the lung or a tumor in the lungs which can secrete argentinophenoma, I think somebody has described that there can be cells in the lungs also. So, but rarely. So, if there is a deposition in the lung and the lung releases serotonin, that can cause left-sided disease. But that's very rare. Usually, it's a right-sided form. So, because of the lack of symptoms, systemic symptoms like sweating and episodes of wheeze, nothing is there. So, I think there is no reason for us to suspect from the story that this patient may be having carcinoid. Okay. Do you think that this can be endomyocardial fibrosis? Nitin, are you there? Nitin? Nikhil, are you there? Nikhil?
Yes, sir.
Yeah. Why can't you answer? Why can't you be active? Do you think that this can be endomyocardial fibrosis? Endomyocardial fibrosis can give rise to atrial fibrillation, all those things. So, do you think that this is endomyocardial fibrosis? Involving mostly the right side?
Yes, sir.
Yes, I think. Can you describe what are the usual presentations of endomyocardial fibrosis? So, what is the hemodynamic abnormality in endomyocardial fibrosis?
It behaves as a restrictive cardiomyopathy.
It's a restrictive cardiomyopathy. It's a form of restrictive cardiomyopathy resulting in stiffness of the ventricle and filling gets impaired. Yes.
And may be associated with the thromboembolic phenomena and arrhythmias.
Yes, because of the dilatation of the atrium and development of atrial fibrillation, these patients can have thrombi, both in the ventricular cavity as well as in the atrial cavity, resulting in embolic episodes. Yes. And patients with, there are two varieties that especially in Kerala it is very frequent. And there are two types. One, those patients have a very fulminant type of endomyocardial fibrosis, which they develop, deteriorate, and they usually die in the second decade. But there is another group of patients where they continue to have very slow progression, and they develop symptomatic only around the age of 40 or 50 years. And I have patients who have given birth to about 6 children without any symptoms, and they presented with the features of endomyocardial fibrosis at the age of 45 or 50. So a second group of patients sometimes can present at a later age, and endomyocardial fibrosis can also be considered as a differential diagnosis, mostly involving the right side. And since there is a symptom of exertional breathlessness, we can also explain by saying that there may be some degree of left-sided disease also. So a biventricular endomyocardial fibrosis can also be considered as a differential diagnosis from the story. Okay. Any other point? Do you think that this is dilated cardiomyopathy? or do you think that this is hypertrophic cardiomyopathy?
HCM, yes.
Edema.
Dilated cardiomyopathy patients can develop edema.
HCM can, because they can present at any age, but dilated, the history is quite too long. So 12 years.
Yeah. And it's only palpitation. Sometimes there can be slow progression.
Yes.
I fully agree with you that the long history, 12 years, and all those things make it the dilated cardiomyopathy less likely. But arrhythmia is a very common symptom of dilated cardiomyopathy. They can develop various forms of atrial arrhythmia, ventricular arrhythmias, and the palpitation can be explained by the development of arrhythmias. So you can, but we'll keep it low in the. Do you think that this is a hypertrophic cardiomyopathy?
No, sir. There is no history of exertional syncope, sir. So it is unlikely.
Is it
Cannot rule out, sir.
exertional syncope? Is it a must?
Cannot rule out, sir.
No, you can see many of the patients with hypertrophic cardiomyopathy may present with exertional breathlessness. Of course, exertional syncope and sudden cardiac death is more frequent in patients with hypertrophic cardiomyopathy. What are the risk factors which can predict that these patients with hypertrophic cardiomyopathy, these group of patients have got higher risk of developing complications? Just a minute. Okay, so in hypertrophic cardiomyopathy, if you want to predict the risk of sudden cardiac death, do you have any clinical points, or what are the points which will help you to categorize an individual a high risk candidate?
Thickness more than 30 mm.
Okay, thickness of the hypertrophied sept more than 30 millimeters. Very good. Yes.
Family history of cardiac arrest.
Family history of sudden cardiac death. Yes.
Patient having history of ventricular tachycardia.
Yes, non-sustained VT on Holter monitoring. Very good. Yes.
History of syncope.
History of syncope. Yes, or giddiness or syncope. Very good.
MRI with
non-response
gadolinium enhancement.
MRI.
More than 50% gadolinium fibrosis.
Oh, how much did you say?
More than 15, sir. 15.
15. Very good. Now, if you do an MRI with late gadolinium enhancement and enhancement of more than 15% of the area of the myocardium, indicating that there is fibrosis, those patients are at high risk. What else? Anything else?
Increment in blood pressure.
Fall in systolic
Drop in systolic exercise test.
Very good. Fall in systolic blood pressure while on exercising. If there is a drop in systolic pressure, that's an additional point for us to believe that this patient is at a higher risk. So there are multiple points, and also patients who develop heart failure. Patients who develop features of heart failure are also higher risk candidates for development of sudden cardiac death. And at what age sudden cardiac death risk significantly comes down?
After 50 years.
60 years. It is said that after 60 years, it is thought that the risk of sudden cardiac death is not different from the regular population. And the life expectancy of patients with hypertrophic cardiomyopathy is considered to be the same as anybody in the regular population. So it is younger population. Usually the sudden cardiac death occurs in younger population, mostly below the age of 40. 40 to 60 is a borderline zone. And after 60, the risk of a sudden cardiac death is extremely low. And nowadays, there are methods by which you can evaluate and predict what is the risk of an individual developing a sudden cardiac death. So we have got methods to find out the prognosis of these patients. But so in this patient, there is nothing for us to suspect that, strongly suspect hypertrophic cardiomyopathy. But since the palpitation can happen in these patients because of an arrhythmia, I would keep low in the list, but I don't want to keep it in high in the list. So, Ramesh, what are our possibilities in order?
First is, sir, congenital heart disease, most likely in the form of shunt lesion at the atrial septum, like ASD. Second is rheumatic heart disease, like mitral stenosis and tricuspid stenosis.
Yes, both mitral as well as tricuspid. Very good. Yes.
Third is Leutenbacher syndrome.
Okay. Why do you say it is Leutenbacher syndrome?
We discussed, sir, there is symptoms of exertional breathlessness and history of palpitation, but as the PND and orthopnea is not there, can be because of the ASD decompressing the LA.
Okay. And what is the hemodynamic change of ASD in a patient with Leutenbacher syndrome compared to normal?
In Leutenbacher syndrome, usually severity of MS decreases because of
not severity. Severity MS does not decrease. Symptoms of MS will not be there. Yes, okay. But what is the effect on ASD? My question is not on what is in mitral stenosis.
Symptoms of shunt will be increased, sir.
Shunt will be increased. There will be a tremendous increase in the shunt, and hence these patients can develop
early heart failure.
Early heart failure. Very good. They can develop early heart failure. Yes, excellent. So here it is 48. So borderline. Okay. So yes. What else do you think that you would like to discuss? Endomyocardial fibrosis?
We can keep in mind, sir, but
it's important to keep in mind so that when you examine the patient, you will be thinking about all the differential diagnosis so that you can make a correct diagnosis at the end of the physical examination.
Yes.
Okay, right. Okay, so shall we go to the physical findings now?
Yes.
Ramesh, okay, right. Yes.
Okay. On examination, patient is not dyspneic at rest. Lower limb edema is present. Pulse rate is 94 per minute. Irregular, varying in volume. All pulses felt normally. No radiofemoral or radioradial delay. Blood pressure 110 by 80 millimeter of mercury. GVP elevated 8 centimeter above the sternal angle. Prominent V wave 10 centimeter in height above the sternal angle and normal descents.
Now let's look at the JVP. What do you mean by what are the conditions in which we can get prominent V waves in JVP?
Mitral regurgitation.
Mitral regurgitation.
Sorry, tricuspid regurgitation.
Yes.
V wave.
What are the conditions in which you can get prominent V waves in JVP?
ASD.
Not ASD. ASD with what?
ASD with MR.
ASD with MR.
ASD with MR.
In a patient with ASD, there can be prominent V waves. Very good. Yes.
LV to RA shunt.
LV to RA shunt. Garbody shunt. Okay. Very good. Yes. What else?
AV septal defects.
Yeah.
RSOV.
Yeah. Rupture of sinus of Valsalva to the
RA.
Right. Very good. So these are the few conditions in which you can get prominent V waves in the JVP. Have you heard of an H wave in JVP? H wave?
Yes, sir.
May I know your name?
Tushar, sir.
Vishal. Okay. Vishal, what is H wave?
Sir, it shows the right ventricular pressure and it comes after the wide.
Okay. It tells you about now what is the mechanism of H wave?
If there is a diastole is longer, then it will sense the RV pressure and give the H wave.
Yeah. See, it usually occurs in patients who have got a slow heart rate. And there is a shallow positive wave before the it occurs before which wave?
A wave.
A wave. It occurs just before A wave. And it is usually because of a prolonged diastole and venous return resulting in some minor elevation of the right atrial pressure. It was described in, I think, 1908. I forgot the name. H wave, the name has come from the first letter of the person who described it. It is known as H wave. It usually happens when there is a bradycardia. And it usually is because of the systemic venous drainage in the right atrium, resulting in minor elevation of the right atrial pressure.
Hello.
Okay. Can you switch off? Can you mute yourself when you talk to in the phone? Okay. What is the relevance of normal wide descent, Ramesh?
Normal wide descent is suggest of there is no obstruction to the at tricuspid level.
It usually means that it's unlikely to have any obstruction to the tricuspid valve. So there is our previous contention that it could be rheumatic heart disease with tricuspid stenosis. Less likely. So the normal Y descent is a point against the
Tricuspid stenosis.
Tricuspid stenosis. Okay, right. Yes. Any other point you would like to discuss here?
The blood pressure is normal. Patient is in atrial fibrillation.
Okay, yes. What will be the, whenever the patient is having a V wave about 10 centimeters, what will be the mean JVP elevation?
Pardon, sir?
Whenever there is a, let us say the V wave and A wave are 10 centimeters in height, what will be the mean JVP elevation? Because JVP is something which many examiners will ask a lot of questions, and unless you are very clear about the description of the JVP, you will be stuck there. So JVP, you have to describe mean JVP elevation as well as the wave pattern. If they, how will you decide about the mean jugular venous pressure elevation?
So it will be around 3 to 4 centimeter less than the maximal heights.
Very good. It is usually around 3 centimeters less than the upper level of the positive waves. So if the prominent V waves are about 10 centimeters, we expect it to be around 7 centimeters. So you can roughly consider that the mean jugular venous pressure elevation will be around 3 centimeters less than the height of the positive waves. Very good. Okay. That also you should mention, because prominent V waves, that is why JVP elevated 10 centimeters above the sternal angle means it is a mean elevation of the jugular venous pressure, and the waves should be separately described. Okay. All right. Okay. Now coming to the precordial examination.
Coming to precordial examination. Inspection, precordial pulsation present. Pulsation are seen in second left intercostal space close to the sternum. Epigastric pulsation are also seen.
Okay.
On palpation,
What are the, when you say epigastric pulsations, what are the reasons for epigastric pulsations?
Right ventricular hypertrophy. Right ventricular hypertrophy.
No, RV hypertrophy usually does not give rise to RV dilatation.
RV dilatation or volume
overload. Because there is a volume overload that you get a large right ventricle, and that can give rise to epigastric pulsation. Okay, right? Yes. What else?
Also aortic pulsation.
Abdominal aortic pulsations. Abdominal aortic pulsation. There's a lot of noise coming. I think somebody can, if people can cooperate, I think the discussion can be without any disturbance. Somebody who is keeping your
Sir, I'll just check into it. I'll just talk to the organizer.
Okay, because that disturbs the discussion.
Yes, sir.
Okay, so epigastric pulsation can be either due to an RV dilatation, or it can be a transmitted pulsation from the abdominal aorta. Okay, right, yes. Okay, now, so we have to differentiate between these two. Only epigastric pulsations are seen. Now coming to the palpation, Ramesh.
Coming to palpation, apex beat is in the sixth left intercostal space in anterior axillary line, diffuse, forceful, RV type. S1 is palpable at the apex, parasternal lift present. The parasternal pulsation extend continuously up to the apex. Pulsation are felt in the third left intercostal space. It's continuous with the lower parasternal pulsation. Systolic thrill felt in the second left intercostal space in pulmonary area. RV pulsation are felt in the epigastrium.
So from these few questions, how will you make out a patient is having RV type of apex, LV type of apex, or a combined?
It looks like RV type of apex.
That's right. Here it is. I am asking a question. Clinically, what are the methods by which you assess whether the patient is having an RV dilatation, LV dilatation, or a biventricular?
If it is down and out, it's LV.
Down and out can happen in RV also. It is not a must, but I agree with you that the down and out is more of a LV feature than RV feature. Okay, but it can happen in RV also. Here it is apex beat is the sixth left intercostal space in the anterior axis line. So it is down and out, and it is said that is RV type.
Just diffuse and continuous with the parasternal.
Okay, that's very important point. The apex beat is if you track the impulse from the region of the apex towards the parasternal region, if it is continuous, and as you reach the parasternal region, it becomes more and more prominent. Then it is the RV forms the apex. 1, 2. How will you make out whether the apex is there is biventricular enlargement?
Sir, if there is space without the pulsation, means apex and RV.
Okay, very good. So you are palpating the apex, mostly localized, or it may be even diffuse also, especially in a volume overload. But then you track medially, there is an area, impulses comes down, and when you reach the parasternal region, again you will be able to feel strong impulses because of the RV dilatation. So if there is an impulse at the apical region, there is a gap, then again impulse in the parasternal region is a biventricular enlargement. And LV type, in LV type, what will be the pattern?
Sir, we can also do a 3-finger test if there is a medial retraction.
Yeah, very good. You get the apex beat is well felt, good for good apical impulse, and as you track medially, the impulse dies out, and then sometimes you can get medial retraction also. That usually indicates that it is a LV involvement with no evidence of RV enlargement or RV involvement. What does this third left intercostal space pulsation mean?
RVOT pulsations.
Yes, one is the RVOT pulsations can be felt in the third left intercostal space. What is the other pulsation which can be felt in the third left intercostal space?
LA pulsations.
LA pulsation, transmitter pulsation from the LV also can be felt at the. How will you differentiate between these two?
Sir, LA will come
LA
late
pulsation will be late systolic.
No, but then that is right. But then how will you clinically make out?
We will auscultate palpate the apex, and at the same time we will auscultate the whatever that is impulse coming with the apex, that is the RV, and after that it is the LA.
Okay, very good. You need not auscultate. You time it with the apex beat. Impulse which coincides with the apex beat is mostly related to the RV outflow pulsations. But if it is delayed, then it is most likely because of the transmitted pulsations coming from the left ear. Okay, very good point. Yes. Okay. So this patient is having a thrill. So systolic thrill felt in the. What does that mean?
Sir, sorry for disturbance, sir. Please, sir.
Okay. Systolic thrill. What is the? Is this patient is having a systolic thrill in the second left intercostal space? What are your thought process?
Mostly because of the pulmonary.
Yes.
Yes. A patient may be having associated pulmonary stenosis, and that can give rise to a systolic thrill. Yes. What else? Yes, you're right.
Pneumatic dilatation.
So what are the? Beg your pardon. Yes. Am I audible to you?
Yes, sir.
What is the mechanism? What are the? I will go ask another question. See, whenever there is a thrill in the pulmonary area or in the aortic area, it is because of an ejection murmur.
Yes,
a mid-systolic murmur, an ejection murmur.
Yes,
what are the mechanisms of production of an ejection systolic murmur?
Either there is a abnormality in the wall with obstruction, so that can cause.
No. You should learn systematically. So, normal flow through a stenosed valve can give rise to ejection systolic murmur. 1, 2.
Increased flow through a normal valve.
Very good. Increased flow through a normal valve. Example?
ASD.
ASD. and also in a patient with aortic regurgitation across aortic valve. In a patient with severe aortic regurgitation, you can get an ejection systolic murmur because of the increased flow across the aortic valve. Third mechanism.
There can be abnormal valve without obstruction.
Very good. The structurally abnormal valve, no obstruction, normal flow. Example? Navjot, example?
Like bicuspid aortic valve.
Very good. Bicuspid aortic valve. That is another mechanism. Okay. Another fifth mechanism. Any other mechanism for production of ejection systolic murmur?
Post-valvular dilatation.
Very good. When there is a post-valvular dilatation, as can happen in patients with aortic aneurysm, or in patients with idiopathic dilatation of pulmonary artery, or in patients with pulmonary arterial hypertension, all can give rise. When a normal valve opens to a dilated chamber, it can give rise to a mid-systolic murmur. Okay, very good. Yes. And finally, sixth mechanism. In patients associated with a reduced peripheral resistance, where there can be hyperdynamic circulatory state. What is the reason? That is because in these patients, the whole of ejection usually mostly takes place during the rapid ejection phase, and that will give rise to an early mid-systolic murmur. And conditions associated with early mid-systolic murmur are anemia, pyrotoxicosis, beriberi. All these conditions can give rise to an early ejection systolic murmur. Okay, so in our case, what are the possibilities? Ramesh, we have already said the patient may be having pulmonary stenosis. Okay, what else?
Increased flow.
Increased flow, because we have thought of the possibility of ASD, and so an increased flow can give rise to turbulence and also even thrill. It is said that whenever there is a thrill in a patient with ASD, you have to think of two conditions. What are those two conditions?
One is Lutemberger.
One is Lutemberger.
Other is concomitant pulmonary valve stenosis.
Very good. So these are the two conditions you should suspect when you are having ASD and there is a thrill in the pulmonary area. You should always think of the possibility of stenosis mild and two, Lutemberger syndrome, where the presence of mitral stenosis makes the left to right shunt torrential, and these patients can have significant stroke volume, RV stroke volume. What is the incidence of pulmonary stenosis in a patient with ASD? Majud?
Yeah, I'm not aware of them.
Anybody? Not very common, but around 10%. It is said that around 10%, less than 10% of patients can have sometimes associated aortic pulmonary stenosis also. Okay, right. So RV pulsation, it is said that RV pulsations are felt in the epigastria. How do you differentiate RV pulsations from the aortic pulsations?
With the tip of finger, sir.
Yeah, okay, very good. If the pulsations are felt at the tip of the finger, it's more likely to be
RV type.
RV. And if it is felt in the pulp of the finger, it's more likely. Okay. What will be the change with breathing?
With breathing, the
RV pulsation will increase.
Yeah, it will become more prominent, and the abdominal aortic pulsations will become
decrease because
less prominent. Okay, okay, right. Okay. Now, so that is fine. Now we'll go to the percussion.
Yes, sir. On percussion, left-sided dullness corresponds to the apex bit.
Okay.
Second, left intercostal space is dull up to the 3 cm from the sternal border.
Okay.
Right border is dull 3 cm to the right of sternum.
Okay. So what are the abnormalities here?
Second, left intercostal space is dull, sir.
It's dull. What is the normal?
It should be resonant, sir, normally.
Up to 1 centimeter it can be dull also. But if it is beyond 1 centimeter, then you have to take it as normal. Here it is 3 centimeters. So obviously it is abnormal. So what are the conditions in which you get a dull note in the second left intercostal space?
Pulmonary artery dilatation.
Pulmonary dilatation, very good. What else?
Severe pulmonary hypertension or LA dilatation.
LA dilatation. How can LA dilate? Where is LA? Is it an anterior structure or a posterior structure?
Posterior.
Posterior structures. That cannot give rise to dullness in the anterior region.
In CCTGA, the aorta may be anterior and left. Sometimes
rarely, but unless I agree with you that the aorta will be in the position of the pulmonary artery, but unless it is dilated, it cannot give rise to dullness and 3 centimeters from the sternal body. Yes.
Right aortic arch.
No, right aortic arch will not give rise to. Will not be in the position of the pulmonary artery. As Navjot said, in a patient with L transposition, the aorta will be in the position of the second left intercostal pulmonary artery position. But then usually it may not extend. Not related to this, another situation where there can be dullness in the intercostal spaces is when there is pericardial effusion. Patients with pericardial effusion can have a dull node in the second intercostal space as well as in the second intercostal space on the left side as well as on the right side. They're not related to this, but for completion's sake. So dullness in the second intercostal space in this patient may be due to dilated pulmonary artery. Okay, right. Yes. Right border dullness 3 centimeters to the right sternum. Again, you are related to
right atrial enlargement.
Right atrial enlargement, and also can happen in patients with pericardial effusion also. There also the dullness can extend on to the right side. Okay, now coming to auscultation.
On auscultation, S1 is heard all over the precordium, best audible at apex, varying, mostly loud. S2 heard all over the precordium, best audible in second left intercostal space, wide fixed split, P2 loud, RV S3 present, fansystolic, high pitch murmur heard from the apex to the pulmonary PS region, grade 3/6, no change with the breathing. Mild ejection systolic murmur at the second
Not
left
mild, mid systolic. Or ejection systolic murmur. Okay,
mid ejection systolic murmur at the second left intercostal space, roughly medium to high pitch.
Actually, when you, 1 minute, Ramesh, when actually mid ejection systolic murmur is actually wrong terminology. Because when you use the word ejection systolic murmur, what do you mean by that?
Murmur starts with the
it is only.
When you use the word ejection systolic murmur, you actually mean 3 things. What are those 3 things?
Ejection murmur occurs in the mid systolic.
Very good. It's a mid systolic murmur. 2.
Starts after S1.
That is why we call it mid systolic. Second is that it is because of an ejection of blood from an LV to a great vessel. And third, it is a crescendo decrescendo murmur. When you are using the word ejection systolic murmur, it does not have the same implication as mid systolic murmur. Mid systolic murmur only means that it's mid systolic. But when you are using the word ejection systolic murmur, you actually mean 3 things. 1, it is a mid systolic murmur. 2, it is because of an ejection of blood from a ventricle to a great vessel. And 3, it is a crescendo decrescendo murmur. So whenever you are using ejection systolic murmur, actually there is no relevance of mid systolic murmur. Okay, right? Yes. Right. Go ahead.
This ejection systolic murmur is conducted towards the left shoulder.
Okay.
Grade 4/6. Mid diastolic rumbling, short murmur, low pitch at the apex. No other murmurs.
Okay. Very good. Yes.
The other system lever is enlarged 3 centimeter below the costal margin.
Now you discuss the diagnosis.
Yes, sir. It's congenital heart disease, sir, mostly.
What do you mean by mostly?
Congenital heart disease.
Don't use unnecessary words because that will put you in trouble. There is no need to use the word mostly.
Congenital heart disease atrial septal defect, um, uh, with pulmonary stenosis. Patient is in atrial fibrillation. NYHE class 3. No evidence of patient is in heart failure. No evidence of infective endocarditis in NYHE class 3 at present.
You are not, one more thing you have to mention. Prominent V waves in the neck. There are prominent V waves in the neck.
Yeah.
So TR. I think you should put that also.
TR.
Why do you want to say that MS is there? What are your points for that?
S1 is loud, sir.
Oh, S1 is loud. Okay.
And then there is a mid diastolic rumble, which is present low pitched at the apex.
Okay, very good.
I like to keep MS also.
Okay, and also you can tell the point that you have already mentioned that this patient is having a systolic thrill in the
second intercostal.
Second left intercostal space, and I feel that this is due to increased flow across the
pulmonary valve.
So I would like to keep the possibility of associated mitral stenosis also. Okay, right? Yes. So now support your diagnosis by clinical findings. Why do you say that patient is having ASD, Ramesh?
First is symptoms, sir. With the history and on examination, patient is having a wide fixed second heart sound.
Okay.
It's most likely because of the ASD only.
Okay.
Wide and fixed.
Can you tell me another condition where there can be wide fixed split to the second heart sound?
RV dysfunction.
Severe RV dysfunction with RV failure. They can have also wide fixed split to the second heart sound. Very good. Yes. So because of the wide fixed split, all these things you think it's a case of atrial septal defect. Okay, right? Yes. Why is this patient is having a loud S1? Mostly loud. What is the reason?
Mitral stenosis.
Can there be loud S1 in a patient with atrial septal defect?
Yes, sir. Loud T1 can be there in patient with ASD.
Why? Mechanism. What is the mechanism of loud S1 in a patient with ASD?
Because of the increased volume or increased volume across the this RA and RV, sir, the tricuspid wall during closure, it closes from wide distance. So there is increase in the.
Actually, in a patient with ASD, normally what is the valve? Which valve closes first?
Mitral.
Why does the mitral valve close first?
Left ventricle.
Contraction starts early. LV contraction starts early.
Why does the LV contraction starts early?
Due to pressure gradient.
Why does the LV contraction start early? In the atrium, which atrium contracts first?
The right
atrium. That is because impulse spreads from the sinus node directed to right atrium, and the right atrium contracts first. Why do you say that LV contracts first?
The left side of the septum depolarizes first.
Yes, the first part of the myocardium which depolarizes first and start contracting is the interventricular septum, and normally interventricular septum forms a part of the LV.
The left ventricle.
But in a patient with volume overload of the right ventricle, what happens to the septal contraction? A patient with RV volume overload, what will happen? You might have done echo in many patients. The patient with the RV volume overload, what will happen to the septal contraction?
The shape of the
paradoxical. There can be paradoxical septal movement. Sometimes the septal movement may be flat, very little movement. or there can be paradoxical septal movement. What do you mean by paradoxical septal movement?
Sir, when this happens when there is a RVH, the pressure hypertrophy of the RV. So when there's a systolic contraction, it will bulge towards the LV.
Yeah.
If it is only a RV volume overload, then it will happen only during the diastole.
That is the
normally the septal moves towards the left
that is
ventricle.
you are describing about the flattening of the septum.
Yes.
But in when there is a contraction of the, when there is a pulmonary artery hypertension and also some degree of volume overload, either septum can become almost no movement at all, or it can move with the right ventricle. So when it moves with the right ventricle, what will happen to the tricuspid closure?
Earlier closure.
It will occur
Earlier, and so that it can actually sometimes sit only. Sometimes what may happen is that there can be the tricuspid closure and the mitral closure can occur simultaneously, resulting in a loud S1. So sometimes you can get a loud S1 in atrial septal defect because of the simultaneous closure of the tricuspid valve as well as the mitral valve. Normally, tricuspid valve closes slightly later than the mitral valve. Here, there is another reason that we are thinking that this patient may be having associated mitral stenosis. And so, in patients with mitral stenosis, you can get a loud S1 because of the wider movement of the mitral leaflets during closure of the mitral valve. So here we are giving two explanations. One, maybe because of the ASD itself, where there is superimposition of M1 and T1, resulting in a loud S1, or it may be because of the associated mitral stenosis in this patient that we are suspecting there can be a loud S1. Okay, right. So you are. What are the, see, normally, what is the mechanism of fixed splitting of the second heart sound in a patient with ASD? Why they have got a fixed splitting of the second heart sound?
Normally in normal individual during inspiration the venous return increases, sir, and so the ejection from the RV to pulmonary artery is later. Hence, there is delay in the P2.
For emptying of the RV takes longer time. Okay, yes.
There is delay in the P2, but in the ASD.
No, that's not enough. There is one more mechanism. See, one is an increase in the venous return. Second is
pulmonary hangout.
Hangout. That's an increase in the pulmonary hangout interval. Why does the pulmonary hangout interval increase during inspiration?
Because pulmonary artery dilates.
Very good. There is a opening up of the pulmonary artery, capillaries, everything, and that will result in the lower pulmonary vascular resistance and hangout interval increases. So, in a patient with ASD, there is a fixed splitting.
So in ASD, when there is during inspiration, when there is increase in the venous return, the shunt from the left side is decreased, and when during expiration, when the venous return is decreased, then the shunt is increased. So there is constant volume present in the.
Whatever is the extra volume of blood that comes during inspiration actually shared between the two sides. When there is a more venous return is coming to the right atrium, then the left to right shunt through the ASD comes down. So obviously meaning that whatever is extra volume coming to the right side is actually practically shared between the two atria. Right ventricle. Okay, very good. In this patient, which one do you think is more likely? Is it associated pulmonary stenosis or is it associated mitral stenosis with an increased flow, which has resulted in the pulmonary artery or second intercostal space 3? Which one do you think is more likely?
Mitral stenosis more likely, sir.
Why? Any one of you.
Sir, if we are thinking that the patient has a ASD plus pulmonary stenosis, then a patient might have even gone with this type of right heart failure, may have a cyanosis also. The shunt would have.
That depends upon how severe is the pulmonary stenosis. Many of these patients have got only mild pulmonary stenosis.
Yes.
Loud P2.
Loud P2 goes in favor of pulmonary arterial hypertension rather than in a valvular pulmonary
Very good. One
stenosis.
point. Second point.
He has a patient has a mid-diastolic rumbling murmur, which can't be explained by the other.
Can be either it can be across the mitral or it may be because of the torrential flow across the tricuspid valve. Okay.
Yes.
Third point. Most of the patients with associated pulmonary stenosis will have. Can one of you complete it?
Mitral regurgitation.
No.
Oh, sorry.
They can have.
Pulmonary rejection.
Very good. Pulmonary ejection click. So if the patient is having a pulmonary ejection click, that would be a point more in favor of pulmonary stenosis. But even without pulmonary stenosis, in a patient with ASD with torrential flow and pulmonary arterial hypertension can have a ejection click. What is the difference between these two ejection clicks? The ejection click because of the pulmonary stenosis is a valvular click, and ejection click in a patient with pulmonary arterial hypertension, pulmonary artery dilatation is a vascular click. What is the mechanism of production of click in a vascular click?
Reverberation of valvular sounds into the dilated arteries.
When the valve opens, normally sound is produced, and that sound is not audible for our human ears. But when it opens and generates a sound, it may reverberate in the dilated artery, and that becomes audible to us. So that is the mechanism of vascular click. Okay, so our diagnosis that we are thinking that there is a possibility of mitral stenosis, so the Lutenbacher syndrome. Okay, yes. Any other differential diagnosis you would like to entertain? Do you think that this can be endomyocardial fibrosis?
Less likely, sir, with these murmurs.
All these murmurs and cardiac enlargement. RV is very powerful. Usually in endomyocardial fibrosis, what happens to the body of the RV?
Obliterated.
Yeah, it's obliterated, and hence you cannot get a very important external pulsation. But you can get a good pulsation in the third intercostal space, because in these patients there is a dilatation of the RV outflow, infundibulum dilates, because that is the only region where there can be volume of blood, and that will result in RV outflow dilatation, and that becomes easily patterned. Okay, so now let's go to some of the investigations. ECG, no, not get the ECG of this patient. What does the ECG? The ECG interpretation is already written for you. Ramesh, you can read the ECG.
Yes, sir. ECG interpretation, patient in atrial fibrillation, rate 90 per minute, QRS duration 0.1 second, right axis deviation, RSR dash pattern in UV1, most likely right ventricular hypertrophy, and RBBV patterns because of the ASD, sir.
What is the criteria for right ventricular hypertrophy when there's RSR dash pattern?
More than 11 mm, sir. RV more than 11.
RV more than 11. Not
For incomplete, it is more than 10, and for complete, more than 15.
No, for the RSR dash, initially if the R wave is equal to or more than 7 millimeters, or R dash wave equal to or more than 15 millimeters, then only you can call it as right ventricular hypertrophy. But 7 or more for R dash 15 or more. Okay, so here we do not know the virus, so we can't be certain about it. Okay, right. Yes, now X-ray test.
Uh, X-ray chest, mostly PAV, sir. There is significant cardiomegaly.
You should say that there is a cardiomegaly on visual assessment because you are not measured it. So you have to say that on visual assessment there is cardiac because you have looked at it and you thought there is cardiac enlargement. Okay, yes.
Yes, sir. On visual assessment there is cardiomegaly. Apex is mostly RV type. RV type
I
apex.
won't commit on RV type, but more likely to be RV type because it is actually it is turning, it is moving in, and there is a acute angle between the cardiac fillet and the diaphragm. So I will agree with you that more likely to be RV. I can't be certain, but I will favor that it is more likely to be RV. Very good. Yes.
MPS dilated,
left part of the heart. Left part of the heart. What are the structures which are formed the left part of the
There
heart?
is straightening of the left heart body.
No, don't use the word straightening and all. You describe it.
Loss of pulmonary being.
No, what is the first
prominent
one? Okay, what is the
Pulmonary artery enlargement, prominent.
what is this? The first one.
aortic knuckle.
Aortic knuckle. Wow. Whatever is against the first anterior portion of the first intercostal space is the aortic knuckle. And the one which is against the second intercostal space is the
Pulmonary
artery. And the one which is against the third intercostal space is the
left atrial.
So here the pulmonary artery segment is
dilated.
enlarged. So what are the conditions in which you can get pulmonary artery segment dilated?
Pulmonary hypertension.
Pulmonary artery hypertension, very good.
Post-stenotic dilatation of pulmonary stenosis.
Very good. Post-stenotic dilatation.
Left or right?
Yes, increased pulmonary blood flow, as can happen in a patient with shunt lesion. Yes, very good. So increased pressure, increased shunt, increased volume, post-stenotic dilatation, and idiopathic dilatation of the pulmonary artery. These are the four situations where you can get pulmonary artery segment prominent. So when we have found a pulmonary artery segment prominent, so we have to look at for other features to find out what is the mechanism which has resulted in the pulmonary artery segment becoming prominent. Yes. And the rest of the left part of the heart, what about, is there a left atrial appendage prominent?
No, sir.
No. And the rest of the left part of the heart is, when you pass over, is normal, or if you want to say, you can say that it seems that it's more like an RV type. Okay. Right part of the heart.
There is significant RA enlargement, sir.
What are the criteria for diagnosing RA enlargement in X-ray chest PAVU?
More than 3 intercostal space.
Okay, more than vertically, if it is more than 2.5, more than 2.5 is enough. 1, 2, there's like 3, more than 2.5 is enough. 3 ribs or more than 2.5 divisions. Okay, right? Yes.
Then right
5
atrial
centimeter from the midline.
5.5 centimeter.
5 centimeter principle applies when you are taking a classical 6 feet or 5 to 6 feet distance X-ray. Nowadays we take a small X-ray, so 5 centimeters cannot be applied. So what can be the application?
3.5.
Not 3.5. What you can do is that you take the right hemithorax and the right border of the heart extends beyond 1/3 the right hemithorax. Getting the point? Normally,
yes, sir.
Normally, right hemithorax is around 15 centimeters. In an adult male, it is around 15 centimeters. That is why original description came as 5 centimeters. Here, since the X-rays are taken nowadays, it is a digital X-ray, smaller in size. Then what you can do is that you take the distance of the right hemithorax from the mid-sternum to the inner border of the right side, in the inner border of the rib on the right side, and if the right border of the heart extends beyond 1/3 of this distance, then that is a point in favor of right atrial enlargement, or right border is extending beyond the normal. Okay, so here obviously it is more than 1/3, so there is a right atrial enlargement. Okay, right. Yes. What else?
In lateral view, this fullness in retrosternal.
Is there any is there evidence of any left atrial enlargement? No, there is no evidence of left lump
Doesn't look
enlargement.
like.
We are not able to see any shadow through shadow. And obviously, this is a slightly underexposed film, so sometimes it's difficult to see the shadow through shadow. But obviously, then nothing is seen here. Okay, and what else? What about the lung vasculature, pulmonary venous hypertension, pulmonary
It
artery
is
hypertension, pulmonary
increased.
plethora? Huh?
Pulmonary vasculature markings are increased.
Okay, pulmonary vascular. There is you think there is a pulmonary. Is there a pulmonary venous hypertension?
Yes, sir.
No, pulmonary venous hypertension. When there is pulmonary venous hypertension, the upper lobe vessels should be equal to or more prominent than the lower lobe vessels. Usually, it is not prominent. I agree with you that it's well seen, but compared to the lower lobe vessels, lower lobe vessels are very big and thick, and I won't consider that pulmonary upper lobe vessels are that prominent. So I will not consider as a pulmonary venous hypertension. Okay. Is there evidence of pulmonary arterial hypertension?
Yes.
From the X-ray test, how do you assess for pulmonary arterial hypertension? Peripheral pruning. Very good. The main pulmonary artery will be dilated. Obviously, it is dilated with significant peripheral pruning. But here the vessels are well tracked to the periphery. So I don't think that there's any significant pulmonary arterial hypertension. Minor pulmonary arterial hypertension cannot be ruled out. But the vessels can be easily tracked to the periphery, indicating that there is unlikely to be severe pulmonary arterial hypertension. Is there evidence of increased pulmonary blood flow?
There is.
What is evidence?
So more than, the vessels, they can be tracked.
Very good. The vessels can be tracked to the periphery. Very good. Yes, what else?
RP is dilated. So.
RPA is dilated. Main pulmonary artery is dilated. Yes, but that is not enough. You have to say something positive to diagnose increased pulmonary
We have
blood flow.
to see the end-on vessels.
Yeah, you have to look at the end-on vessels. And what is the criteria?
More than 6. It should be larger than the accompanying bronchus, sir.
Okay.
And usually in the periphery, the vessels should be more than 6, which we can track.
Okay. And also, what should be the number of end-on vessels?
So 6, 3. I'm not sure, sir.
5.
Yeah. It is more 3 or more on one side, more than 3 on one side, or both sides put together more than 5. So if it is, you are looking at one side, if it is more than 3, yes. But if you are looking at both sides, if it is more than 5. So here I think there is one, sometimes maybe 2 here, 3, 4, 5. I think plenty of them. So I think there is evidence of increase in the pulmonary blood flow. Does it support our diagnosis?
Yes, sir.
Yes,
Definitely there is ASD. We can't be certain whether there is a
MS or not.
MS or not. How do you assess the extent of shunt? Is it a large shunt or a small shunt?
So again, the pulmonary blood flow, we can see if the pulmonary blood flow is increased, we know it's a significant shunt, sir.
Okay. What else?
Dilatation of pulmonary artery.
Very good. What else?
Thrill also suggests, sir, there is a large pulmonary blood flow.
Which one?
Thrill in second.
Eh?
Thrill in the second intercostal place.
No. I'm saying I have X-ray chest.
End-on vessel suggestive.
Yeah, that's already mentioned. The end-on vessels indicate there is a increase in the pulmonary blood flow. Another cardiac
RV enlargement.
Cardiac enlargement.
Yes.
Cardiac enlargement X-ray chest is a sign of increase in the volume of blood. And in a large, as a patient is developing less and less shunt, the heart size will come down. So increase in the size of the heart is an indirect evidence of increased shunt. So this patient is having cardiomegaly, end-on vessels are seen. So obviously the ASD is torrential. There's a large ASD flow. Okay, right? Yes. Now let's look at what next is there. Oh, okay, there is a hemodynamic data. No, you don't worry about the age of the person because it is taken from another person. Don't worry about the age of the person. Rest of the things. Okay, interpret the hemodynamic data. This is not of that patient, but this is only a exercise to discuss the hemodynamics. How do you discuss the hemodynamics? Ramesh?
Yes, sir.
Or anybody can discuss. How do you discuss the hemodynamics? You have to discuss the pressure data, then you have to
and oximeter data.
oximeter data. Very good. Yes. How will you proceed to discuss the pressure data?
So here RA pressures are normal,
Okay.
sir.
RA pressure, you have to look at the pressures and comment whether it is normal or not. Okay. So here RA pressures are normal. We are not with this patient because in this patient we are not expecting a wave. Okay.
Yes,
Right.
sir.
Yes. RA pressure is normal.
RV systolic pressure
Yes,
is
okay,
increased,
right.
sir.
RV systolic pressure is 50 and diastolic pressure is
Diastolic pressure is normal, sir.
Very good. Yes.
And pulmonary artery systolic pressure is also borderline or increased.
Systolic pressure is increased. Normal upper limit of systolic pressure is
30.
30. Here it is 40. So it is elevated. Diastolic pressure is normal. Mean pressure slightly elevated. Mean pressure is normally is up to 18. So 20 is slightly elevated, but not significantly. Yes.
Wedge pressure is normal.
Okay.
LA pressure is normal, sir.
Okay.
LV and aortic pressure is also normal.
Okay, right. There is no gradient. Okay, right. Yes.
In the oximetry,
now there is a data on post exercise.
Post exercise.
What has happened?
LA pressure has increased.
LA pressure is
slight increase in the LA pressure. That is something which has been described in patients with associated mitral stenosis. When they exercise, there can be an elevation of the slight elevation of the LA pressure. So here is a slight elevation of the LA pressure. That will be an additional point for you to support the diagnosis of
mitral
associated mitral stenosis. Okay. Oximetry data.
There is step up at the RA level,
okay,
sir.
there is a significant step up. What step up will you consider significant?
7. Mean more than 7, sir, at RA
Okay,
level.
mean more than 7. Or if it is a single sample, if it is more than
11. Than 11.
11 or mean is 7 or single sample 11. Okay, right. What else? Anything else? Any step down? There is no step down. Everything is fine. So, of course, you know how to calculate, and also obviously, diagnosing this patient is.
So there is ASD.
Atrial septal defect, and also with exercise, the LA pressure has gone up, so there is associated. Echo has confirmed that the patient has got both atrial septal defect and mitral stenosis. So I could not take out the echo, so that is why I could not show you that. Now, coming to the management, how do you manage this patient? Ramesh, would you like to discuss the management?
Yes, sir. So we have to first do the echo and see what is the quantity of shunt. We have to see the
quantity of shunt is assessed by the oximetry that we have got evidence that there is a good shunt. You have to evaluate the pulmonary. What will be the? How do you calculate the pulmonary vascular resistance? Ramesh, what is the formula for calculating the pulmonary vascular resistance?
Sir, pulmonary arterial pressure minus pulmonary wedge pressure divided by pulmonary flow divided by pulmonary artery pressure minus pulmonary wedge pressure.
Pulmonary flow divided by pulmonary
mean pulmonary artery pressure
minus not pulmonary artery wedge pressure, but it's left atrial pressure. Left atrial pressure. Ideally, it's left atrial pressure. Mean pulmonary artery pressure minus left atrial pressure. Then what did you say?
Pulmonary flow.
What is the formula to calculate pulmonary vascular resistance? That's the question.
Pulmonary flow.
Pulmonary artery pressure minus left atrial pressure divided by pulmonary blood flow.
Oh, yeah. That's a formula. Why did you say, Ramesh, that it is pulmonary blood flow divided by pressure difference. No, it is the pressure difference divided by flow.
Pulmonary.
So the mean pulmonary artery pressure minus expiratory pressure divided by pulmonary blood flow. That will give you the pulmonary vascular. Here in this patient, pulmonary blood flow is tremendous. So pulmonary vascular resistance should be normal. Okay. Now coming to how do you investigate? How do you decide to manage?
We have to assess the mitral status of the mitral wall.
Very good.
What is the significant, whether mitral stenosis is significant or not? What is the status of the wall?
Okay.
Whether it is thick, whether it's rheumatic affection, calcification, everything we have to see.
Okay, but mainly you should look for what? Whether the patient is a candidate for
BMV.
BMV, yes. Whether we can do an interventional treatment in this patient by looking at how do you assess a valve for suitability for balloon mitral valvuloplasty?
We have to see by the Wilkins score, sir.
Yeah, Wilkinson score. And what are the parameters that you look at for Wilkinson score?
There are four parameters, sir. Calcification of the wall, thickness of the wall, subvalvular apparatus, and
mobility of the wall.
So they're grade 1 to 4, and if it is total score is 8 or
more
less,
than 8,
and that is mostly suitable. But some people say even up to 10 is all right, but 8 or less is definitely suitable for procedure. Okay, right. Yes, the ASD, how will you assess?
So transesophageal we can do, sir.
Yes, you have to. Ideally, you should do a transesophageal echo to assess the
rims of the ASD.
Rims of the
to
ASD.
see the suitability of the device.
Okay. What is the rim size that you require minimum?
Voice is breaking, sir.
Is my voice breaking?
So voice is breaking, sir.
Okay. How will you assess the suitability of the patient for a device procedure to close the ASD?
Rim size should be more than 5 mm, sir.
Ideally, it should be more than 5 mm. But what is the area where you can even go without the significant rim?
Retroaortic will be usually less.
The aortic region, we can even with less or sometimes even without a significant ring, people accept the patient. So the rim is very important. So if there is a good rim all around, 5 millimeters all around, then it's most suitable. So we will look at the rim suitability for a device procedure, and if valve is suitable and the rim is also suitable for, or the ASD is suitable for a device closure, what will be our management?
DME and ASD device closure.
Okay. Can we do ASD device closure only?
No, sir.
Pressure is increased.
No. Why we should not do it?
If that will ASD will be closed, LA pressure suddenly will increase and patient will go into the pulmonary edema.
So if you close the ASD in presence of mitral stenosis, immediately the left atrial pressure will go up and the patient can go in for pulmonary edema. So first the ASD, the mitral valve should be tackled, then only you can think of doing a device closure. Okay, right. Yes. If the patient is having a valve which is unsuitable for a procedure, balloon mitral valvuloplasty, then what is your approach?
Surgical.
Then you should recommend a surgical.
Both
repair, ASD repair.
Yeah, one thing that surgeon can try to surgically open up the stenosed valve. If that is not possible, then the patient has to undergo a valve replacement, artificial prosthetic valve replacement, and ASD can be closed. Okay. What are the complications of device closure?
One is embolization.
Embolization of the device, yes. Where does it embolize to? Is it on the right side or left side?
Right. Mostly left
mostly,
side.
Is it mostly to the left
Right
side?
side. Right side.
Mostly to the right side. Why?
Because the left pressure is high.
Yeah, left atrial pressure is high, and mostly it embolizes to the Right side. Okay. Right. What are the complications of device closure?
Heart blocks can occur.
Not very commonly.
Erosions of the.
Yeah, there can be erosion, late complications, and erosion can happen. Yes.
The residual shunt.
Residual shunt, very good. Excellent. There can be residual shunt, yes. And if the size, how do you assess the size of the disc?
Mismatched prostatic patient.
Yes. So, in order to avoid a prostatic mismatch, how do you assess the size of the device that you will use?
One is with the balloon.
One is with balloon. Very good. Yes. Excellent. And what should be the size of the disc in relation to size of the defect?
It should be more than 2 mm more than the balloon size.
Yeah, very good. It should be ideally it should be more than 2 millimeters in extra than the size of the measured size of the defect, so that it fits in very well. Okay, right. How long will you give aspirin, clopidogrel, whatever it is? What is your regime?
6 months.
3 months. 6 months.
6 months.
3 to 6 months. Even 3 months is enough, but you can give for 6 months. One. Second,
Endocarditis
endocarditis prophylaxis during the first 6 months. So 6 months usually give aspirin and also infective endocarditis prophylaxis. Okay, good. I think you could discuss reasonably well. Any doubts you want to clear about points that we have said?
Sir, was there a valvular PS in this case, sir?
No, there was no valvular PS. It was all due to increased flow across the pulmonary valve. And also the gradient that we measured in this patient, if you are not this patient, it's only 10 millimeters. That is not enough to diagnose a PS in the sense of a large shunt. In the sense of a large shunt, people have described a gradient even up to 25 millimeters across the pulmonary valve without any organic stenosis. Any doubts you want to raise or clarify?
Sir, during cardiac catheterization, exercise, post exercise, how to take exercise?
Leg exercise. You make the patient do a leg exercise. If you have got a bicycle, you can ask the patient to do a bicycle exercise, or you can raise and lower the leg, or only one leg. If you are putting the catheter from the right leg, you can do only the left leg. Even that is enough.
Sir, in case of AF S2 with AF with MS S2, how we can assess?
That I think we'll discuss when we discuss a case with MS with aortic stenosis. Now, any doubts about this case? No.
No, sir.
Okay, that's fine. I think then we'll take it as a. Next week, what do you want? Is it you want a case discussion only, or you want X-ray discussion or echo? I think I will take a class on hemodynamics. I think you need a good idea about hemodynamics and how to analyze the hemodynamic data. Shall we do that?
Yes, sir.
Hemodynamics. I think you should get a correct concept about hemodynamic data and its interpretation. So this class will be on hemodynamics, so that you will get a correct concept. So if there are no more doubts, I think we'll. I think it's 9 o'clock. I think we'll stop at this level. I think Ramesh, I think you did reasonably well. There were some hitches here and there, but mostly you discussed. I think you were steadily improving. I think the answering also has been showing steady improvement. It's not good signs, and very good. Okay, right. We stop at this level.
Yes.
Fine, great.
Thank you, sir. Thank you.
Thank you, sir. Good night, sir.
Thank you, sir.
Bye.
Thank you, doctors. Next Friday, same time, 7 o'clock, we will start the session.
Same time. Same time.
Jinoy?
Yeah, Siddhi, you can close the session.
Okay, I'll stop the recording also.
Yeah, thank you.